Good morning, everyone. When I began my career as a nurse, I did what many nurses are expected to do, which is to get 2 years of med-surg experience in a hospital. But I was very lucky because the place I found a job was Harborview Medical Center, the county's sort of primary safety net hospital for traditionally underserved populations. And Harborview gave me those 2 years of med-surg experience, but it gave me much more than that. Because its mission populations are incarcerated individuals and homeless individuals and immigrants and refugees and IV drug users, I got a really deep education in the social reasons why people end up in the hospital. And they had nothing to do with individual choices or healthcare factors, but really things that started way upstream. I really loved my work there, but I also felt a frustration at the inability for me to sort of help affect those upstream factors. So I saw the same heroin users come back over and over, the same homeless persons come back over and over again. So I became an epidemiologist, and again was lucky enough to get a job at the public health department here in Seattle, King County, where I was trying to address sort of those same issues, but on the population level. I thought maybe there would be a different approach if we looked at it not just at the individual level, but at the community level. And today, I'd like to talk with you about my experiences on a particular sort of focus of that work, which is working to improve the sharing of health and social information across sectors, with a focus on how to use that information to advance health equity. I'd also like to make a pitch to increase opportunities for more nurses to serve as cross-sector data sharing champions, which is a phrase that hopefully will become more familiar in a minute. First, a little background for context. So as we know, there are many barriers to improving the health and well-being of our nation's population, and they include challenges in addressing the social determinants of health in a meaningful way, and fragmentation in the delivery of healthcare, social services, and public health services in most communities. Here in King County, as is true in many areas across the nation, there are many cross-sector partnerships that aim to address health and social needs by working across that clinical and community space. In our work at the Public Health Department to support and be part of such partnerships, one thing we've noted is that successful partnerships typically require some level of information sharing across partners. And that information sharing, for a variety of reasons, including data privacy laws and regulations, becomes more difficult when those partnerships include non-clinical partners, such as housing providers or jails. And so with that in mind, I'd like to focus on two things today. First, a value proposition, that is, how cross-sector data sharing can be used to advance health equity. And second, to describe a potential role for nurses in supporting cross-sector data sharing. The value proposition begins with embracing the concept of social determinants of health. That is, that health begins where we live, learn, work, and play. As both a staff nurse working at a county safety net hospital, as well as an epidemiologist at the public health department, I've noted that efforts to improve health that stay solely within the healthcare delivery system are incomplete because they fail to really affect those upstream drivers of health. These social determinants are even more critical to consider when working with traditionally underserved populations, where deep social disparities lead to inequitable differences in healthcare and health. In King County, as is true again in many areas, one approach to addressing social determinants of health is cross-sector partnerships, which work at both the individual and the community level to sort of avoid the crises that we try to avoid, to eliminate health and social disparities, and to optimize quality of life. To be successful, again, many of these partnerships require some level of information to be shared. So you can imagine, for example, a housing and hospital partnership where there's efforts to improve access to affordable housing for traditionally underserved populations. How would you evaluate the impact of that program if you only had healthcare data? Similarly, how would you evaluate the impact of the housing program on health if you didn't have that information sharing? The current state of data and information systems in most sectors, whether you're talking about clinics or jails or schools or housing providers, it makes this sort of information sharing challenging. And the reason is that we still see a state of data fragmentation. That is, where data systems are program specific and largely are not designed to talk with each other. At the individual level, the impact of this is that health and human service providers struggle to access information about the whole person. also struggle to coordinate services across delivery systems. And I remember that as a nurse. I worked night shifts for 2 years. I had access to my electronic health record, which was great, but I couldn't always find the information that I really wanted to about what the patient really needed at the time, even if it was within the healthcare environment, like whether they had a vaccine or not. At the population level or the community level, where I work now as an epidemiologist, we struggle to access information about the whole community and to measure progress towards elimination of health and social disparities. So for example, a healthcare provider may fail to realize that a patient's frequent interactions with the criminal justice system are making it more challenging to manage their behavioral health condition. And at the population level, a public health department may see a place-based disparity in behavioral health prevalence, but not see an associated place-based disparity in criminal justice system involvement. So we see an incomplete picture. To address this data fragmentation locally here in Seattle, the Public Health Department and many other organizations have invested in cross-sector data sharing. Most of my work over the past 6 years at the Public Health Department has been focused on this effort. And through this effort, I have learned that cross-sector data sharing is both an art and a science. I mostly see the art of data sharing in the process of building the trust that is necessary for sharing information across sectors. Trust is built through the formation and strengthening of cross-sector partnerships, which are human relationships both within and across organizations. Building a common language to describe the mutual benefits of data sharing is essential for this process. One value proposition we use frequently in King County is how this data sharing can be used to support health equity, which I'll speak more of in a minute. To sum up the foundational importance of trust, I like to use the phrase, data flows at the speed of trust. There's also a science to data sharing, including many supporting factors such as data privacy laws and regulations, information technology, processes to assure data quality, and approved use cases, which are sort of policies that say who can access what information for what purpose. I'm going to show a few examples of recent and ongoing cross-sector data partnerships in King County. The Health and Housing Partnership was built around the linkage of health insurance claims data and public housing authority data, primarily to serve the aim of the public housing authorities to understand the health needs and the healthcare utilization patterns of their clients, and then begin to develop an ability to measure the impact of their programs on the health of their clients. In the center, we linked health insurance data, electronic health record data from the jails, behavioral health treatment data, and criminal justice system data to evaluate the impact of a jail-based continuity of care program on the health of inmates once released from jail. This was a great pilot effort because historically, this program had only been evaluated using criminal justice data, so whether someone comes back to the jail. But the program wasn't designed to target criminogenic risk factors. It was designed to improve health, but they never had an ability to look at that. On the right, our county's Accountable Community of Health, an organization called Healthier Here, is using Medicaid claims data, behavioral health treatment data, and 211 calls, or calls to a social service hotline, to identify focus populations for healthcare transformation strategies under our state's Medicaid waiver. Across all of these cross-sector data sharing partnerships, the Public Health Department played a role as a convener, as a data recipient, and as the organization that linked and analyzed the data to answer the common questions asked by partners. I want to use that last example, the Accountable Community of Health, to illustrate how cross-sector data can be used to advance health equity. So King County's Accountable Community of Health is using linked Medicaid data and behavioral health treatment data, two data sources that are traditionally kept separate from each other, to identify focus populations for a program that will aim to divert Medicaid members from using the emergency department for more appropriate health and/or social services. In this slide, we see use of the emergency department for 4 Medicaid populations in King County. In gray on the left is the overall Medicaid population. In blue are members with a behavioral health need only. In orange are members with a chronic illness such as asthma, diabetes, heart disease only. And in green are members with both a behavioral health concern and a chronic physical illness. Now, having either a behavioral health need or a chronic illness alone does increase your risk of using the emergency department for any reason. But having both really leads to a substantial increase. Seeing those data, the Accountable Community of Health wanted to focus its ED diversion strategies on members with both a behavioral health and a chronic illness. But it first wanted to check for additional disparities by other member demographics, such as race. And so on this slide, we see ED visits for the same population, but broken out by race and ethnicity. Now, the stark disparities we see here led us to further questions and analyses, which began to unpack what are the reasons why people are using the emergency department. And through those analyses, we found that certain causes, such as alcohol use disorder, were much more common in certain racial ethnic groups than others, and very highly associated with the use of the ED. All of this information about healthcare disparities was shared by the organization with its various committees and stakeholder groups, and is being used to validate its selection of focus populations for its ED diversion program. Without the ability to link the physical health data and the behavioral health data, we would have only seen a fragmented view. And in that fragmented view, we may have come to different conclusions about which populations have the greatest room for improvement on a particular measure. Those incomplete conclusions would lead us to incomplete priority areas, and those help drive funding decisions. And so it really is important to see as much as possible of a community or an individual when we're trying to prioritize where we focus and how money is spent. One final point about this, we've noted that when you link data across sectors, we're also often able to fill in missing information about individuals, which increases our collective ability to look at disparities in the first place. I want to bring us back to the importance of building trust across sectors to support data sharing. A trusting relationship, in my experience, is essential both for that initial data sharing relationship or agreement, as well as maintaining it and renewing it over time. In my experience, I've come to see nursing practice as particularly useful in building that initial trust for a few reasons. One, nurses are trained and well-positioned to see the person behind each data point. It's grounded in their direct service experience. I have found this particularly helpful when I'm trying to assure data stewards that we respect the clients behind their data and that we'll do everything possible to safeguard its confidentiality. Nurses are also familiar with the practice of cultural humility. That is, the process of stepping outside yourself, recognizing others' identities, and validating their perspectives. I have found cultural humility to be very useful in cross-sector data sharing relationships because it's essential to validate the opinions and priorities of each partner. We need to get to that sort of mutual language of why data sharing is important and can help all sectors, and cultural humility is useful there. Finally, nurses are expert negotiators. There have been many times when I've been in a meeting going over some dry section of a data sharing agreement, it seems like the 100th time, when I remind myself, wait a minute, if as a nurse I was able to convince a confused and scared patient withdrawing from alcohol in the middle of the night to let me insert a tube down their nose to administer a medicine, surely I can negotiate this data sharing agreement. Once data starts to flow across organizations, I've turned to public health practice to really deliver on that value proposition of showing through data linkage, assuring the data quality through mapping and analyzing data, and then disseminating the results in a variety of formats, including interactive websites, the answers to questions. So it's a really good blending of these two fields. So to close, I want to leave you all with a key message and a few potential options for consideration. As expert negotiators with a practice grounded in person-centered care and cultural humility, nurses can serve as effective cross-sector data sharing champions. How might we support more nurses to pursue this role? One idea, provide financial support for nurses to attend public health educational programs. I can say, for one, once I started my public health education, I really wish that I had taken that EHR data sort of reporting a lot more seriously, because I could see how that data is used for a variety of ways. Two, support or strengthen academic partnerships between nursing schools and public health systems. And three, recruit nurses to lead cross-sector partnerships with a focus on those partnerships that include social service and public health systems. Thank you for the opportunity to share my experience.
Thank you, Eli. Now I'd like to welcome Stefan J. Torres to the podium.